And then, there are the stimulants, which I think are helpful medications in our population of patients. These are some of the typical dosing ranges. There are a variety of formulations that of each of these agents that can make the medication act short-acting, intermediate-acting, or long-acting. Typically, with the short-acting formulations, you'll prescribe it in the beginning just twice a day, I think, but you can do up to 3 times a day. But you don't want patients taking it, sort of after 4 or 5 p.m. I usually only start with to see if it works, in the morning, and then another dose in the afternoon. But these are helpful not just in addressing depression, but also can help with fatigue, and can help with some of the neurocognitive ramifications of actually chemotherapy. They've been shown to be helpful in that regard as well. There's another agent called Provigil, modafinil, which is thought to be have less of a risk for abuse, and that is true. It is not effective for ADHD. It's less. I mean, there's mixed. But there's mixed results for that, but generally it's not used for ADHD. It's used mainly as a wakefulness promoting agent, but it has been also shown to be helpful in chemobrain, in addressing chemobrain. There are fancy formulations of these medications that prevent abuse. There's a new drug called Vyvanse, which is an old stimulant, dexedrine, basically with lysine on it that prevents it from being that requires that it be metabolized by the gut, so you can't inject it. The longer acting formulations, also similar to the opioids, have less abuse potential in theory, because they don't have the quick on, quick off effect. We don't really have to talk too much about these because I'm running out of time to talk about anxiety. But some of the mood stabilizers in treating bipolar disorder are also helpful in pain. So that's something that's helpful to know about. Like Depakote and Neurontin. Well, not so much Neurontin, but Depakote is something that is a more, I say, psychoactive anticonvulsant. A lot of the other anticonvulsants have been tried as mood stabilizers, but have not been shown to be as effective for bipolar disorder. Neurontin really is not. It can help with anxiety a little bit, though it's not typically prescribed for that. But it's not, in my experience and from what I know, helpful with bipolar disorder or bipolar depression. Lamictal or lamotrigine is particularly helpful for bipolar depression. And then some of the antipsychotics I actually added are being shown to have some benefit as adjuvants or even primary treatment for depression. Rarely prescribe it as primary treatment, but adding Abilify can be helpful for depression, and it's less sedating than Zyprexa and Seroquel. And obviously, with the first 2 medications in particular, you have to be careful of the metabolic side effects. These are some of the side effects that are associated with antidepressants. I think I mentioned most of them. The SSRI side effects, a lot of those that are listed go away over time as you get adjusted to the dose. Most common side effect of SSRIs is, I think, decreased libido or actually anorgasmia. I mean, that happens very commonly with SSRIs and can be treated sometimes by adding Wellbutrin, actually. And as I mentioned, stimulants are used, in the general population really as adjuvants for depression, but in the palliative care setting, particularly with people who are near the end of life, are helpful for treating primary depression. But I wouldn't hesitate to start an SSRI with the idea that it's going to take a long time to work, because they're generally well tolerated. So if it's appropriate, it's worth trying. So I don't even know if I have time for anxiety, but maybe I'll just skip ahead to talking about some of the treatment for anxiety. Let's see. Well, I just want to say a word about the primary disorders of anxiety. Again, adjustment disorder is a common diagnosis with features of anxiety. But one thing that one thing that we sometimes don't pay attention to, specifically in cancer treatment, are post-PTSD type symptoms related to the illness and the series of traumas that one goes through when over the course of one's illness, specifically with cancer, related to receiving diagnosis, to getting radiation. People do often, even long after they're in remission, experience numbing or hypervigilance and PTSD-type symptoms that are related to their cancer, and it's something that we're paying more attention to now. Certainly, phobias can be common with any medical illness. Needle sticks, phobias about hospitals in general become generalized to hospitals, or claustrophobia is commonly encountered with patients who are having to have radiation simulation or have to undergo MRI. I'm not even going to have time to address most of these, but I do want to get just to some of the treatments. Just a discussion briefly about the pharmacotherapy. In general, again, I think using benzodiazepines, especially those that are, used as anxiolytics as opposed to, to address other problems, is helpful in the acute stage, but that shouldn't. The idea is that shouldn't really preclude considering starting an SSRI. Benzos can be helpful for, I would say, subsyndromal, anxiety symptoms, acute anxiety. But if someone has generalized anxiety, you're not going to be, around-the-clock benzodiazepines is not something that's recommended, especially short-acting benzodiazepines like Xanax or Ativan. Klonopin is a longer-acting medication that has been used alone, long-standing, for treatment of generalized anxiety disorder. But again, I prefer to have someone at least tried on an SSRI before I just have them undergo treatment with sole benzodiazepines, because you can develop, again, a tolerance to these medications. They can be habit-forming and can end up being used inappropriately, and are medically, I think, more risky in some ways than the SSRIs. Because even with SSRIs, you can have a withdrawal syndrome, but withdrawal from a benzo can be particularly severe. So the important thing to know about the benzodiazepines is that actually Ativan actually only on this slide is not metabolized really directly by the P450 system, so it's much safer in patients with hepatic impairment. The drugs that are safe in patients with hepatic impairment include the benzos include Ativan, Serax, and temazepam, which is a Restoril, which is a sleep, more used for sleep as opposed to anxiety. It's a little longer acting. And Klonopin is actually relatively safe with patients with hepatic impairment. It is metabolized by the P450 system, but by the liver. But it's and specifically, the others are by glucuronidation. This one is metabolized by the P450 system, but it doesn't have active metabolites, so it's a little safer than, for instance, Valium in patients with hepatic impairment. I actually don't often. I think Valium is something that is often used in the medical setting. I haven't really used it much in the psychiatric setting. It's used a lot, I think, for treating withdrawal symptoms, but again, it's long-acting. It has active metabolites. It can stay in the system for a long time, but it's helpful as a muscle relaxant. So, that's the end of my talk.